Hi again. We are moving on to discuss communication techniques with mental health clients. The first thing that I just wanted to mention is therapeutic touch in mental health nursing. Nurses, we are very caring. We like to put our hand on somebody's shoulder, hold their hand, rub their back, just show some affection and empathy with clients. And I would caution you in the mental health setting about using therapeutic touch. Um, you are dealing with individuals who have a mental illness, and so therefore their thoughts and perceptions are skewed. Okay, so that therapeutic touch can be interpreted in a way that we did not intend it to be. It could be interpreted as aggression or attacking, all depending on the client that you're working with. So I would caution you and would suggest that you may not want to use therapeutic touch in this environment. And if so, minimally and perhaps with permission from the client. Okay, advance please. I'm having the same problem, you guys, with this not advancing. Okay, let's see what I can do here. I apologize. Oh, come on. Oh, well, look at that. And it jumps all over the place. Okay, let's try this again. Okay, so here we go. Factors that affect communication, right? You can, see this picture and review it. But basically, personal factors would be, mood, response to stress, personal bias. So, excuse me, social factors would include previous experiences, cultural differences, language differences. Cognitive factors would be things like problem-solving ability, knowledge level, language use. The environment that we're in has a lot to do with how our relationship is established. Are there physical barriers like background noise or lack of privacy or too cold or too hot of a room? So we have to think about those physical factors. Societal factors like presence of others, expectations of others, those all also contribute to this relationship. The status of the individual in terms of social standing, power, relationship types, age. It's not a one-way street, right? Hearing, looking at nonverbals, our body language, how the patient is talking to us, processing information, communicating. We are looking at all those things in our patients, but they are also looking at all of those aspects in us. So how we want the patient to react to us should be the same expectations that we have of ourselves for meeting their requirements. Active listening. Oh, jeez. I'm just going to keep talking because this is not progressing for me. So on your PowerPoint slide, you can see that the next PowerPoint slide would be active listening components, right? So we are observing nonverbals. We are listening to understand. Oh, there it went. We're understanding things in the context of the individual's life. We're going to be using clarifying statements to make sure that we're understanding what the person is actually saying, restating or paraphrasing what they've said and asking them if that is correct. And we're listening for inconsistencies in stories. This becomes very important when we'll talk about violence and abuse, elder abuse, child abuse, domestic abuse. You get inconsistencies in stories. So one thing about body language that I wanted to call your attention to is another acronym that I tend to like to use is called SOLER, S-O-L-E-R. And what it means is when you're talking to somebody, you want to S, be sitting squarely in front of them, O, have an open posture to interact with them, L, leaning kind of forward a little bit so it shows interest in what they have to say. E is establishing eye contact. And R is having a relaxing conversation with them, not that you're uptight or drilling them, okay? Physical characteristics are your facial expressions. Again, eye contact. The way you or the person holds their heads, their leg, their shoulders. Are they cross-armed? Are they, what is their body language? So a person who is slumped over avoiding eye contact or sitting with their arms crossed may seem uninterested or resistant. So we have to be very careful about body language. Proximity is going to be very important in your mental health rotation because you want to provide enough distance from yourself to give the patient a feeling of comfort and you a feeling of comfort, and also maintaining a distance that's safe enough that if something should change or become negative, that you are a safe distance from them to protect yourself. So an intimate distance would be like 18 inches from the person, and this reserves personal space for both people and builds trust. A social distance, would be like 4 feet, and that is, the distance that I would suggest if you're trying to maintain safety or you're concerned about safety. Okay. Understanding the context of the person's life. So listening for the bigger picture. Many times the patients have multiple things going on in their life that contribute to their current disease and stressful situations. So trying to take all these pieces and put it together and how it affects them globally. And again, clarifying, restating, paraphrasing, all those therapeutic communication techniques that I referred to in the last recording that are posted on Blackboard. The use of silence. So explore those again, please. Okay, so the clinical interview, here are some guidelines, okay? Speak briefly. Many times the client, on the initial meeting is not going to want to talk. They don't trust you. Just sitting with the person is going to again start to build that bridge. Open communication is very important. Things to remember, you want your patient to be talking more than you are. Remember, in your assessment, it's about observation and it's about subjective information. We don't have a lab or an x-ray to look at to determine that there is a problem, right? We don't have those physiological things when we're dealing with mental health. What we have is that person's perceptions, how they're presenting themselves as clues into what might be going on in the brain. So make the patient talk. It's not about us, it's about them and how they perceive things. Don't offer opinions or how you handled situations because you are different. You're a different person than they are. You want to explore what they've done or not done for that matter. Try to understand their feelings. Okay, in the first meeting you have with the patient, you're going to go in, you're going to tell the patient who you are, the purpose of your presence, and how long you're going to be, working with them. And again, you're going to want to stress the confidentiality unless, there are some extenuating circumstances in which we are obliged to share that information. When you don't know what to say nothing. Again, silence can be difficult, very difficult for us because we like to talk. But it can be very therapeutic for the mentally ill patient. And it's okay to respond, I just don't know what to say to that, because that's honesty. If you're honest with them, they're going to respect you and trust you more. Focus on their feelings again. What is the message that they're trying to give you? Advice, remember, do not give advice. In the end, it will bite you. So suppose you gave a mental health patient some advice on what he should do. Say he's having trouble in his job, and you say something like, well, I would suggest that you talk to your boss and you let him know that you're not comfortable with what he's doing. So the client might take your advice and go and do that and come back to you and say, I did this because of you and now I lost my job. So, you really have to be careful and refrain from giving advice on what the client should do. Instead, what you should do is say something like, let's think about your options. What are some positive and negatives, and let's write them down. And then put the ball back in the patient's hand by asking them, so what do you think you should do? That's always a good way to handle a situation like that. And don't rely on asking questions. Avoid question after question after question. The patient is going to feel badgered, they're going to feel defensive, and it's not going to produce what you're looking for really, and is that interactive, goal-oriented relationship. So, especially avoid using closed-ended questions. You need to think about more gentle ways to get the information out of them, giving them feedback or paraphrasing what they're saying, showing empathy. So you might say something like, well, it sounds like you're really going through a lot right now, or you're really having difficulty with that, or tell me a little bit more about why you feel that way. Or what's another one? Something like, I wonder what else was going on when you experienced this. It leaves that door open for the client to elaborate on what they're trying to tell you. And remember your nonverbals. Are they focused, or are they, more concerned with things that are going on around them? Are they fidgeting? What's their body language? And then you can use this nonverbal behavioral language to help them recognize some of their symptoms or how they're exhibiting themselves. So suppose you have somebody who is real fidgety or something, and you could say to them like, I see you are tapping your foot today. Are you nervous about something? And that opens the door not only to make them cognizant about their own behaviors, but to try and figure out unconsciously maybe what is prompting that kind of behavior. So again, focus on the client. Don't give a lot of your own personal information to patients. It's not a good idea. Always keep the focus on them. Give empathy, but don't focus on how you handled a situation. Focus on how they handle a situation. And the communication level should be the same. So what I'm trying to say is like, be very cognizant of if you're standing and the client is sitting and they get that impression that you're in a position of power. Be really cognizant of that. So you want to make sure your interactions are on the same height. You're both sitting or you're both standing. You're slightly angled again towards them, showing interest. Be sure that you put safe distance between you and the patient if there's a safety concern. And, avoid things like you sitting at a desk and the client sitting across the desk from you, having those physical barriers in between you. So help the client. In summary, this is what we are trying to establish or accomplish with mental health patients. We want to identify and explore problems. Help them explore what's going on. When did it start? Are they doing anything about it? Discover healthy ways to meet those emotions. Coping mechanisms. Are there coping mechanisms that can help or hinder them? Experiences, you want experiences that are satisfying. You want a good relationship with them. Help them identify resources that they may have with family or the community, and to draw on those upon, when they're having difficulty. Making them feel understood and comfortable and safe. Okay? And in summary, the clinical interview should avoid these types of tactics. This may be simple, easy, and straightforward, and it doesn't need to be talked about, but it's amazing how much you can see these communication errors occurring in the mental health setting. So arguing, saying your patient was telling you that he or she's going to do something that you do not agree with. We need to find suitable ways to talk to them about it and not argue. Patients at times have a way of elevating your responses or misinterpreting them in a way that was not intended by you. Try to avoid minimizing things, making statements like, oh, that's nothing, or that's no big deal, or oh, it's going to get better, you'll be better in a little while. Statements like that minimize and make them feel small and that you don't care about their issues. Giving false reassurances, I think I already covered that. Probing sensitive areas. If somebody says that they don't want to talk about something, then we need to respect that decision and not push them. Again, let the patient set the pace. Trying to sell a client on accepting treatment. So, trying to sell them on a voluntary admission to the hospital, or trying to sell them on taking the medications. Really, it has to be, the patient has to make their own decisions, and we have to respect those patient decisions. We want to avoid participating in criticism of other staff. Many of the mental health illnesses actually will utilize manipulation and playing staff off of one another, so we have to be very careful about that. And then joining any attacks led by the client. So if a patient is talking nasty about another person, we need to intervene and shut that down. No one is to pick on another person ever. And again, bullying or passive-aggressive behavior is, one of the things you will see when you're dealing with mental health patients. And that will end our communication. And the next recording will be on stress and crisis. Thanks for listening.